Six, five, four, three, two, one. Good evening. This is Dr. John Bennett, broadcasting from Miami. Tonight we have a continuing one in the continuing series of Google Hangouts regarding Parkinsonism education, and we have Dr. Abdul Rana, a neurologist from Toronto, who's also a world-renowned Parkinsonism educator. He's with us tonight to talk about dopamine and Parkinsonism. Good evening, Dr. Rana.
Hi, Dr. Bennett. How are you doing tonight?
Very good. Well, we had a little tech problems, but we got through it, and looking forward to hearing from you. Okay, let me start things off with a question. How are the brain and basal ganglia related?
The nervous system is anatomically divided into central and peripheral nervous system. The central nervous system consists of cerebral hemispheres, brainstem, and spinal cord. The peripheral nervous system starts from the nerve roots and nerve plexus, and then peripheral nerves which exit from the spinal cord. The different areas of brain, they perform different functions such as language, perception, memory, and judgment. The three parts of brainstem are midbrain, pons, and medulla. The brainstem controls the critical movements or functions such as consciousness, eye movements, swallowing, and breathing. And the pyramidal tracts or the motor pathways, they start from the cerebral hemispheres, they go through corona radiata, internal capsule, and then they synapse on cell bodies in the spinal cord. Now from the spinal cord then originates the peripheral nervous system. The sensory pathways, they start from the periphery and they enter the spinal cord and then they ascend towards the cerebral hemispheres. Now the top of the cerebral hemispheres makes up the gray matter and below which is the white matter, which makes up the nerve fiber tracts. Now coming back to basal ganglia, within each cerebral hemispheres on both sides are the deep masses of gray matter which are called basal ganglia. The basal ganglia are caudate, putamen, globus pallidus, subthalamic nucleus, and substantia nigra. The substantia nigra is located within the ventral midbrain. The caudate and putamen are also called striatum, and the globus pallidus has two parts. It has globus pallidus interna and globus pallidus externa. And substantia nigra, which lies in the ventral midbrain, it has two types: the substantia nigra pars compacta and substantia nigra pars reticularis. The nigrostriatal neurons, which start in substantia nigra and they end in striatum. So the neurodegeneration in Parkinson's disease involves these particular neurons. Now, the putamen and globus pallidus, sometimes they are also referred as a lentiform nucleus. The cerebral cortex, the top of the cerebral hemispheres, it sends an input to the striatum, which is the caudate and the putamen, and from striatum, this input goes towards the globus pallidus, which is the main source of output of basal ganglia. Now, the globus pallidus is then connected to thalamus, and from thalamus this output goes back to cerebral cortex, completing the whole cycle. Now this degeneration of these dopaminergic neurons in the substantia nigra is the cause of loss of dopamine and is the main biochemical abnormality in Parkinson's disease. The cortex, which the striatum, which is the caudate and the putamen, is the main source of input to the basal ganglia, and the globus pallidus is the main source of output of basal ganglia. Now, the subthalamic nucleus has a very important connection and a role in this pathway, and it is overactivated in patients with Parkinson's disease. The basal ganglia have a greater role in the modulation of motor behavior rather than execution of the movements. The basal ganglia and cortex, therefore, are connected through a pathway which is quite complex and is called cortico-striato-pallidothalamo-cortical circuit. Now, the abnormality or alteration in this circuit causes Parkinson's disease. The basal ganglia are highly organized, and different parts of basal ganglia play different roles. The basal ganglia are also involved in associative memory, working memory, learning, emotions, and planning. Now, this circuit of basal ganglia can be studied through two types of systems. One is a direct pathway, which is through the globus pallidus, internus via striatum, and then back to the cerebral cortex. And the indirect pathway is through globus pallidus internus via globus pallidus externus. Now, the cortico-striatal afferents, they inhibit the medium spiny neurons in the indirect pathway, and they facilitate the direct pathway. So the globus pallidus plays a key role in regulating this motor output of basal ganglia. The depletion of dopamine interferes with the cortico-striatal balance, and it causes the overactivity of indirect pathway and underactivity of direct pathway. So how the alteration in subthalamic nucleus takes place is not exactly understood. This model of direct and indirect pathways was introduced in the 80s, and it is an oversimplification, but it did help to advance the research, and also it is a tool for the revival of the neurosurgical interventions in Parkinson's disease. However, as I said, it is an oversimplified model. The direct pathway bypasses the subthalamic nucleus, and the dopamine facilitates the direct pathway and inhibits the indirect pathway. So in patients with Parkinson's disease, most experts believe that the direct pathway is attenuated or weak, and the indirect pathway becomes overactive or it becomes strong. So as a result, the movements become slow because the dopamine facilitates the direct pathway, which facilitates the movements. In Parkinson's disease patients, the direct pathway becomes underactive, so movements become less. And the indirect pathway, which leads to lack of movement, it becomes overactive. Therefore, the most important or the key symptom of Parkinson's disease, which is bradykinesia, it becomes apparent in these patients.
Oh, very good, Dr. Rana. What is the role of the dopaminergic neurons?
With respect to neurons, before we move to dopaminergic neurons, we'd like to review the basic neuronal cells in brain. So brain has two types of cells, neurons and the glia. The glia are involved in insulation and myelination, scavenger function, CSF production, whereas neurons, they are involved in sending impulses from one part of nervous system to the other part. Now, each neuron has a cell body which is surrounded by a cell wall, and the cell body contains a nucleus, which has missile substance also, and is involved in protein synthesis. So on one side of cell body, there are finger-like projections, which are called the dendrites. Now on the other side goes a tube-like structure, which is called axon. And from this axon, there are other finger-like projections, axon terminals, which make connection with the dendrites of the other neuron. Now, the dendrites of one neuron, they are separated from the other neuron by a gap, which is called synaptic gap. And the transmission of signals through this synaptic gap occurs through chemical substances, which are called neurotransmitters. Now, coming back to the different types of neurons, so brain has different types of neurotransmitters, such as acetylcholine, serotonin, norepinephrine, and dopamine. And these different neurotransmitters have different functions, and they have different groups of cells which produce these neurotransmitters in different areas of brain. The dopamine-producing neurons, they are found mainly in substantia nigra of midbrain, and they are called nigrostriated neurons because their cell bodies lie in substantia nigra, and then their axon goes, and they go towards the striatum. Therefore, they called nigrostriatal neurons. Now, when there is degeneration of the cell bodies in the substantia nigra, so this leads to less production of dopamine because the dopamine is produced in cell bodies. So as a result, from substantia nigra to striatum, the flow of dopamine decreases, which leads to lack of movements. And when a patient is usually manifesting the symptoms of Parkinson's disease, about 50% of the dopaminergic neurons have already degenerated. Now, dopaminergic neurons, they exist in two states of activity. So some of the neurons are non-firing neurons, the other neurons are firing neurons. Levodopa, which is the main source of treatment of Parkinson's disease, it activates the non-firing neurons, and as a result, the dopamine is released. So when levodopa goes, so it stimulates, and these medium-sized non-spiny neurons, which are located in midbrain, they have lots of branches. So they are called highly arborized, and a single neuron may transmit signals to up to 1 million other terminals. So these dopaminergic neurons, they have a firing rate between 4 to 5 hertz, which is considered a low frequency firing rate. So the other neurons, which I just mentioned, the non-firing neurons, they serve as a reserve population of neurons, and they are stimulated whenever there is a behavioral demand. So the levodopa causes some of its effects by increasing the dopamine output through these non-firing dopaminergic neurons. This tonic activation of these neurons due to levodopa, however, it could be like a two-edged sword. On one side, it increases the dopamine output, but it may make the system more susceptible to disruption by increasing the demand. So the dopamine release or dopamine transmission occurs through two types of releases. One is a high amplitude, brief, phasic dopamine release. It is short lasting. It is a high amplitude, more release, but it is only phasic and brief. And the other release is more of a long duration, but low amplitude and a tonic release. So This phasic dopamine release, which is brief and high amplitude in large amounts, this occurs in response to a behavioral demand, whereas the tonic dopamine is released as a steady state in the population of the spontaneously active dopaminergic neurons. So when we look at the dopaminergic neurons in the ventral midbrain, they are divided into three main categories: the A8 neurons, A9, and A10. The A8 neurons are also called the retrorubral field. The A9 neurons are substantia nigra pars compacta, and the A10 neurons are ventral tegmental area neurons. Now, in the substantia nigra pars compacta, the neurons are further divided into a dorsal tier and a ventral tier. Now, the dopaminergic neurons in the ventral tegmental area and in the substantia nigra pars compacta dorsal tier, they are much less sensitive to neurodegeneration in Parkinson's disease as compared to the substantia nigra pars compacta ventral tier neurons. The other areas of brain with dopaminergic neurons beside the substantia nigra are locus coeruleus, dorsal motor nucleus of vagus nerve, substantia innominata, intermediolateral column of spinal cord. The dopaminergic degeneration in other parts of brain, which one I just mentioned, it may start even much before the degeneration of neurons in the substantia nigra, and therefore most experts believe that the non-motor symptoms, which may come in many cases before the motor symptoms, they result due to the neurodegeneration in these extra-niagral areas. So those neurons which are surviving, so they contain the Lewy body inclusions, which have a pinkish core and they have a clear halo around them. Now these Lewy bodies, they are highly sensitive for Parkinson's, but they are not specific for Parkinson's disease. These Lewy bodies, if they are diffusely present in brain, so in that condition, most patients exhibit symptoms of Lewy body disease.
Doctor, how do the neurons become degenerated? How do they degenerate?
The exact mechanism how the dopaminergic neurons degenerate remains unclear. However, it could be the acceleration of the normal mechanism of cell death, which is apoptosis. So another cause could be that the nerve growth factors, which are required for the growth of nerves, they may be deficient in these patients. And when neurons they work to produce energy, they use oxygen, and in this process, a lot of toxic substances which are harmful for the cells are produced. And these toxic substances, they should be cleared. So when they are not cleared properly, the accumulation of these toxic substances takes place, which causes neural cell death. The dopamine is produced by an amino acid, tyrosine. Now the source of this tyrosine is diphenylalanine. There's a enzyme, tyrosine hydroxylase, which changes this into L-dopa, and then L-dopa decarboxylase changes L-dopa into dopamine. This L-dopa decarboxylase is a vitamin B6 dependent enzyme. The other neurotransmitters, such as norepinephrine, so they could be deficient in patients with Parkinson's disease, although the primary deficiency of these neurotransmitters is not the characteristics of Parkinson's disease, but reports have shown a reduced norepinephrine concentration in 4 brains of patients with Parkinson's disease.
Okay.
There is, there is some evidence for motor and cognitive dysfunction of noradrenergic systems in these patients. The serotonin is another amino acid which may be less in patients with Parkinson's disease. This neurotransmitter, serotonin, is present in the raphe nuclei of brainstem. Although there is no evidence that the primary deficiency of serotonin specifically is the result of Parkinson's disease, but decreased serotonin levels have been found in forebrains regions of patients with Parkinson's disease, especially in striatum, substantia nigra, and hippocampus. With respect to acetylcholine, the principal site of cholinergic neurons in basal ganglia is the cholinergic interneurons in striatum. So there are some changes in the acetylcholine as well. But some experts think that these could be in response to a defective regulation as a result of decreased dopamine level rather than primary involvement of cholinergic neurons. There have been some reports of decreased choline acetyltransferase, which is an enzyme responsible for the synthesis of acetylcholine, which may lead to then a decreased acetylcholine level in these patients. The main neuropathological feature in patients with Parkinson's disease is the loss of neuromelanin-containing dopaminergic neurons in nigrostriatal pathway, which causes the depletion of dopamine and results in bradykinesia and other symptoms of Parkinson's disease. Some of the PET studies have also shown that the motor symptoms of Parkinson's disease before they become clinically apparent, the disease process starts between 4 to 5 years prior to that stage, and these neurodegenerative changes are not just limited to the nigrostriatal pathways, but they do involve many other dopaminergic and non-dopaminergic cell groups, such as locus coeruleus, nucleus basalis of Maynard, as well as raphe nuclei, and they may cause other non-motor symptoms such as cognitive dysfunction, and unfortunately, some of these symptoms may not improve with levodopa. Therefore, the definite diagnosis of Parkinson's disease can be only made by the autopsy when you don't find these dopaminergic neurons and there is a significant loss of nigrostriatal neurons, and you can see Lewy bodies in those neurons which are surviving.
Okay, doctor, very good. Now you mentioned Lewy bodies. What are Lewy bodies?
Lewy bodies are eosinophilic spherical bodies which are aggregates of alpha-synuclein, ubiquitin, as well as parkin. Now, these were initially described by a German pathologist, Lewy, and they were named after him. So Lewy bodies are considered a hallmark of Parkinson's disease, and they are not only present in substantia nigra in patients with Parkinson's disease, but other parts of brain such as dorsal motor nucleus of vagus, locus coeruleus, nucleus basalis of Maynard, hypothalamus and intermediolateral column, as well as ventral tegmental area, dorsal tegmental nucleus, periaqueductal gray matter, subthalamic nucleus also have the Lewy bodies. And the other parts such as olfactory bulb and central pontine gray matter, as well as PPN nuclei who have Lewy bodies are considered to be the cause of the non-motor symptoms, which in some cases may appear much before the motor symptoms. Now, these Lewy bodies, although they're sensitive for Parkinson's disease, but they are not and are specific for Parkinson's disease because they can be seen in other conditions as well.
Very good. I think that's a good overview of dopamine and Parkinsonism. Anything else to add before we close, Dr. Rana?
It's a very complex pathway of basal ganglia connections and their function. The text, the material which we spoke is although seems to be to be to be to be going along with the explanation of symptoms of Parkinson's, but I think it's too simple. There are too many complex connections which we still need to understand more and study them more. Although some of the symptoms are explained by these models which we were speaking, but it's not at all specific for or at all not explanatory for many other symptoms of Parkinson's disease.
Very good. Well, thank you, Dr. Marna, for another excellent presentation in the series on educational videos on Parkinsonism. We'll be back tomorrow night at 9:30 p.m. Eastern Standard Time for another educational episode in Parkinsonism. Good night, Dr. Marna.
Thank you very much. See you tomorrow.
Thank you.